Thank you, sir. So I'll be summarizing the whole day's program, spine blocks for neurosurgeons, and I'll try to emphasize on certain particular blocks which have not been discussed at a greater length. So why should I learn blocks? It helps clinch diagnosis many a times, and especially if we are taking up the patient for surgery, and it is definitely a part of the treatment algorithm. What are the blocks I would be talking about? Erector spiny block, it's a plain block. Transforaminal block we have already discussed in the morning and we have demonstrated it as well. Facetal block, that means intrafacetal injections. Then medial branch blocks for facetal pain. Epidural blocks, the various types we have already discussed. Caudal block and SI joint block, they have already been discussed, just the previous lecture was on that. So why blocks? Because there is a poor association between imaging and the cause of chronic pain. So that is why the blocks come into place, so that we are very sure that what we are targeting, even surgically, we are at the right place. And surprisingly, only in 15% cases, the source of chronic pain can be picked up through imaging alone. So, it is so less. We need to use diagnostic blocks more often. Now, how to go about diagnostic nerve root block? It helps diagnose the source of pain, pinpoints the pain generating root level or the facet joint. You can use lidocaine, which is a short-acting drug, small amount, 0.5 to 1 ml. And if the patient has 50, some studies would say 50%, but generally we agree that 70% is the mark. If the patient has 70% or more pain relief, we consider it to be a positive test. The diagnostic value of any diagnostic nerve root block or facet block is only moderate. So clinical imaging as well as the diagnostic nerve root block. The frequency of blocks that we can give is about 3 to 4 per year is safe for a particular level. And there should be a gap of at least more than 2 weeks. What are the contraindications? Anticoag, local site infection, systemic infection, pregnancy, use ultrasound only, and if there is allergy to contrast or local anesthetic agents. We've had an extensive discussion on the type of steroid. Again, I would emphasize that I personally believe in dexamethasone. The particle size is 10 times smaller than that of a RBC, and they do not aggregate. So dexamethasone is the drug of choice for me, and there's no difference in studies as far as functional or analgesic outcome is concerned between the particulate or the non-particulate steroid. The rationale for steroid use, I'd like to draw your attention to this epidural steroid versus just bupivacaine injection in disc prolapse. Epidural steroid injection patients, 23% required surgery, whereas just the bupivacaine group required 67%. So obviously you need to use steroids. Rationale for local anesthetic, the viscosity is different. Local anesthetics is similar, and there is higher viscosity of the dye. So the dye would spread less, and the local anesthetic would spread more than the dye. The volume of drug would decide the specificity. So suppose if you're putting 4 or 5 ml, then obviously there will be extensive spread, and you cannot be very sure about the level of the block. And so lower volume for selective nerve root blocks and SI joint or facet blocks, and higher volume spreading to adjoining structures and decreases the specificity. Rationale of epidural steroid. Now this is very important. The SPORT trial, which is the spine patient outcome research trial. Patients of disc herniation receiving epidural steroid, only 20% of them required surgery. Whereas without epidural steroid block, almost 57 to 60% required surgery. So sort of we can avoid a lot of discectomies if we are using the blocks. Now coming to transforaminal versus interlaminar, TF approach has better results, lower complications, and obviously better ventral penetration of the drug, because in these cases and at times with osteophytes or cysts, you may have anterior compression and the root is also lying anterior in the foramen. So transforaminal tends to deposit the drug there. In pregnancy, kindly use ultrasound. Now let us compare fluoroscopy versus CT scan. Now fluoroscopy is faster, widely available, easy to use, better non-axial view, real-time view of the flow of dye. And the disadvantage is radiation to the surgeon and obviously non-axial views. Whereas in CT, you have excellent axial views and 3D views, precise view of where exactly your needle tip is. However, and also operator radiation is avoided, but the disadvantage is time taking, increased radiation to the patient, and real-time views are absent. So every time you tend to come out. So let's look at erectus spinae plane block. It is the new child around the corner. It was just started 2016. It's a facial plane block, and the drug is deposited below the erectus spinae muscles. So I personally use for peri-op pain reduction for my lumbar surgeries, as well as if I'm doing thoracic surgery. However, it was introduced for thoracic surgery and for chronic pain. So part of it is ESPD block, like for all of us, it can be utilized as the multimodal analgesia. So it is part of the ERAS program now. The target is the tip of the transverse process. You can do it fluoroscopic or ultrasound guided. The needle rests on the tip of the transverse process below the erectus spinae muscle. And I personally use 20 ml of, I use ropivacaine, 0.2%, deposited on either side. So if I am doing just an endoscopic disc or a tubular disc on one side, then obviously I'll just pushing the drug on one, but suppose if I am doing some sort of fixation, I tend to push the drugs on either side. Now, what is the current standing? The conclusion is erectus spinae block provides less opioid consumption, lower pain scores, and longer time to first analgesic in the perioperative period. So obviously, if you're using it, you can enhance the recovery. Complications, you can have partial lower limb weakness, complete motor block, priapism, local toxicity to the anesthetic drug because you're injecting a lot of it. Transforaminal blocks, we have already discussed at length in the morning, so I'm not going to that. Facet, I'll focus on a few very important aspects, which are practical tips. 67% of neck pain is secondary to facet, especially chronic neck pain. 48% of thoracic pain and 45% of low back pain. I must tell you, 10 years before, I hardly thought about facet as the source of pain. So many patients coming to my clinic. And this data sort of opens our eyes to the times we are missing the cause of the pain generator. This has already been shown, the presentation of facet-mediated pain. Basically, it's a diagnosis of exclusion, but the patient can come with lumbar back pain, aggravated on hyperextension, rotational movements. Uncommonly, it will spread to the lower limbs up to the knee. Generally, it does not go below the knee, so you can differentiate with the radicular symptoms. In cervical, Professor Dureja has already discussed, this is the pattern you will get, but no radicular pain into the upper limbs. Coming to intra-articular facet blocks. So facet as a source of pain, basically it's a diagnostic block, not very good therapeutic option. The causes of facet joint pain can be osteoarthritis, rheumatoid arthritis, Angst-Bond, segmental instability, trauma, inflammatory post-laminectomy, and post-spinal fusion. Again, I would emphasize that a good number of our patients, when we fuse, they complain of back pain, and we do not listen to them. We just keep on using analgesic, physiotherapy, and gabapentins and pregabalins. Please think about facet as a source and at least do a diagnostic block. Now, as far as intra-articular facet joint block is concerned, you need to push in less than 1.5 ml because otherwise there would be capsular rupture or leakage. For cervical facet, you can use a short-acting local anesthetic, whereas in lumbar you can go in for a long-acting one. This we have we've had so much of discussion since the morning, but you can see the facetal line here and you just need to push the needle straight in, do the dye. Let's look quickly onto the studies. I think my time is over, so let's skip this. Medial branch block, just one comment. So for say L4-5 facet joint. So the question is, suppose if you have a L4-5 facet joint, the supply is coming from, one is coming from the L4 ramus and the other is coming from L3 ramus. But to simplify L4-5 facet joint, you use L4 pedicle area and L5 pedicle area to block. Okay, so that will give you a good median branch block. To remember, these are the exceptions to the dual supply: atlanto-occipital joint, atlanto-axial joint, and C2-3 joint. They just have singular supply. Technique has already been discussed. The best is between the mammillary process and the accessory process, but the midline is good enough because most of the times on fluoroscopy this is not seen. Complications, this I would like to focus. Multifidus is supplied by medial branch, and it is very important for stability, so avoid more than 3-level median branch block because it will cause innervation and instability. This we have already seen in the morning during our session. We did interlaminar, midline 2, we did one paramedian, and transforaminal we did several. So this we have already discussed, I need not go. Just the final slide on epidural and anticoagulant consensus. NSAIDs, no contraindication. Eclopidine, discontinue for 14 days before the procedure. Clopidogrel, 5 days. Heparin, discontinue 2 to 4 hours prior, check the PTT, and then you can go ahead. Warfarin, discontinue 5 days, get the INR normalized. Low molecular weight, wait for 24 hours after the last dose. So I think I'll sum up my lecture here in the interest of time. Thank you so much.
We would like to have some questions.
Yes,
Any
sir.
question to Dr.
Because we are talking